Now, Martin's, I'm going to embarrass him a little bit because he's a hero of mine, because I read an article by Randolph Nesse about evolutionary psychiatry, and then I got Martin's first textbook of evolutionary psychiatry, which was an eye-opener and was an inspiration for us starting all this EPSIG. So I wanted to thank him very much for that book, and also the many other books and papers that he's written. And it was a great pleasure meeting him in Erice last year. And we've sort of got into communication and writing a chapter in this book that Riyad and I are co-editing. And it's been very, very fruitful. So I'm really looking forward to your talk now, Martin. And I hope we haven't shortchanged you too much time-wise on a Friday afternoon. Have you got your volume on?
Yes, yes. Thank
Lovely.
you.
So over to you. So wonderful. Thank you.
Thank you so much, Paul and Riyad, for inviting me to give a presentation this afternoon. And I'm also incredibly grateful to the previous speakers, because I have an easy task, at least the first warming up slides will be kind of short summary of what we've heard already. I work with young adults who 90% of whom have borderline personality disorder, and that's why I'm going to talk about adult attachment and life history patterns in this clinical population. Yeah, a tribute to John Bowlby for his for the first and as far as I can see, only evolutionary theory in psychiatry and psychotherapy. And you see on the left-hand side the cover of Jeremy's wonderful book about John Bowlby and attachment theory, and a quote of John Bowlby's himself on the right-hand side concerning human nature. So I think in addition to attachment theory, we've learned a lot already about that from Annie's presentation, is that it's easy to combine this with biological ideas from life history theory, which is basically a theory derived from what is called behavioral ecology. And the original idea was to provide understanding why different organisms or animal species differ so much in terms of their reproductive patterns and life histories. And this is illustrated on this in this slide, comparing mice and elephants. And you can easily grasp, I think, the idea that mice are on a much faster track in terms of their life history strategies, where strategy is not, of course, a term suggesting conscious decision making. So mice and other rodents, rats, for example, reproduce fast. They have a low survival rate. They have very many offspring per litter, for example, but their maximum lifespan is usually very short. And in addition, and that's part of the focus of my talk today about borderline patients, is that they usually don't need to invest much in somatic or body maintenance. So in other words, these short-lived animals have much more frequently cancers and other diseases that indirectly relate to the low or poor somatic maintenance of body function. And on the right-hand side, you see the opposite strategy: slow reproduction, high survival rates, few offspring per litter, and high somatic maintenance. And of course, all primates, including our own species, belong to the so-called K-selected pattern, where K stands for capacity and R for reproductive rate. So that's the idea of behavioral ecology, to explain that in dangerous environments, it's advantageous to pursue a fast reproductive strategy, where in more stable environments, it pays off more if a species pursues a case-selected strategy. And the novel idea, we've heard already about it, first put forth by J. Belsky and colleagues now already 30 years ago, was that the R and K spectrum not only applies to differences between species, but also between very subtle differences within species, including our own species. And Belsky and colleagues called this type 1, which is the fast strategy, and type 2 strategy, suggesting a slower life history strategy. And this idea is fully compatible with attachment theory. So in short, as regards type 1 strategy, and I have to repeat, there is no conscious decision-making involved, high stress levels in the family are predictive of harsher and more rejecting or insensitive and inconsistent child rearing practices by parents. And this makes it more likely that the child develops insecure attachment patterns, so-called mistrustful internal working models, a term coined by John Bowlby, as we know. And this may lead to more opportunistic interpersonal orientations. The new idea, and this is very fascinating to me, is that such a developmental track apparently leads to earlier somatic, including sexual maturation and early onset of puberty, whereby the data are more robust for girls than for boys. And again, what follows from this developmental pathway could be that these individuals engage earlier in sexual activity, have more often short-term unstable pair bonds, and as we've heard from Annie's talk, this could be a way of transgeneral transmission of such behavioral patterns with limited parental investment when growing up. And type 2 is the exact opposite, akin to the K selection strategy. Right. So, as we've also heard, different attachment patterns do not necessarily involve anything that is healthy as opposed to pathological. So even insecure attachment patterns can be adaptive in certain environments where, again, the type 1 strategy could be more adaptive in biological terms in unpredictable or unsafe environments, whereas type 2 strategy is perhaps more adaptive in predictable or safe environments. And individuals perhaps may make unconscious predictions about future resource availability based on their very early or their earliest experiences with caregivers. So in other words, life history suggests that individuals adjust their risk-taking behavior to their, a very technical term, residual reproductive value, that is their expected future fitness. Individuals with relatively high expectations, the K version, should be relatively risk averse because they have to survive to realize those expectations. And by the same reasoning individuals with relatively low expectations should be relatively risk prone because they have little to lose. When talking about within species variation, the terms R and K selection are usually not used, but a common term introduced into the literature is so-called pace of life, which more or less has the same meaning as fast or slow life history strategy. A good colleague of ours, Marco Del Giudice, who is originally from Italy but working in New Mexico, has published several very, very good papers on individual differences with regard to life history strategies. And he was arguing that we can identify psychological properties that are more likely to occur in people pursuing a fast strategy as opposed to a slow strategy. For example, social antagonism, unstable attachments, precocious sexuality, promiscuity, and so forth are more likely to be linked to a fast strategy, as well as executive functioning problems like disinhibition, impulsivity. Personality traits like low conscientiousness and low agreeableness are more likely to be associated with a fast strategy, as well as I said before, early and faster somatic maturation occurring in harsh and unpredictable environments. This is a slightly different presentation with a very similar meaning. The slow strategy is associated with careful consideration of risks, long-term thinking or planning, pro-social behaviors, satisfying relationships, mental and physical health, parental investment is high, and higher earning potential is all of this. These are associated with a slow life history strategy. So this could suggest that people with borderline personality are among those who are unconsciously, of course, on the fast track. If you look at these criteria taken from the DSM-5, you see that many of them are more or less identical to what I've shown in the previous slide. And as you know, 5 of 9 are sufficient to arrive at a diagnosis of borderline personality disorder. So a couple of years ago, I wrote a theoretical article suggesting that borderline personality disorder could be an exemplar of a fast life history strategy that needs to be addressed therapeutically. And Jeremy has already said one key could be to push the pause button on that fast track. But as a downside, I would like to mention that there is huge diagnostic heterogeneity of BPD. It's not quite like playing a lottery with 6 out of 49 or so, but 5 out of 9 allows 126 different phenotypes of BPD when applying APA or DSM-5 criteria. So that's something we need to keep in mind when talking about BPD in general. Okay, we know that early adversity, like especially childhood neglect, emotional abuse, sometimes sexual abuse, is very prevalent in that group of people. And in our clinical samples, at least among our inpatients, we have figures of about 80 to 90% who in one or the other way have experienced childhood trauma. So let me briefly summarize a few clinical aspects. It's known that the lifetime prevalence of BPD is quite high. Several studies suggest a prevalence of 1 to 2% in the general population. Some say it might be even up to 6%. And definitely it's more frequently found in clinical samples with figures of at least 15% or even more in psychiatric hospitals as a comorbid condition at least. There's a debate about the female to male ratio. In clinical situations, it's more like 3 to 1. Some people suggest that if you look at populations in jails, you will find all the males with BPD, but this is something I wouldn't like to talk too much in my presentation, because the data I would like to present you in a couple of minutes are exclusively about females with BPD. Onset is in early adulthood. Childhood abuse already mentioned, and comorbid depression is common, whereby genetics of BPD are still kind of inconclusive. But in regard of what I said about life history and poor body maintenance, it's really alarming to look at these figures that, for example, the risk for cardiovascular disease is 7 to 8-fold higher in people with BPD compared to the general population. There's also elevated risk for diabetes, hypertension, liver disease, inflammatory, including autoimmune disease in this population, and also increased rate of obesity. So these are quite alarming figures with regard to possible measures of preventing somatic disease in people with psychiatric disorders. So what we actually did very recently, this is unpublished material or submitted material, is we wanted to explicitly study what's called pace of life or life history strategies in people with BPD using a scale called Arizona Life History Battery, which is a composite score of different measures tapping into executive functioning, the quality of kin and friends relationships. Adult attachment is part of that scale because it incorporates the experience of in close relationships scale. Altruism is another factor, and this makes a composite score of that scale called ALHB. We also measured allostatic load. Allostatic load is a concept put forth by Bruce McEwen, suggesting that the accumulation of somatic consequences of chronic stress leave a somatic mark on the body, and that can be measured by different somatic or constitutional features like systolic and diastolic blood pressure, the waist to hip ratio, body mass index, and in addition, inflammatory markers in the serum, which we couldn't do because we had basically no money for that, or very few money for that study. We also measured personality dimensions using the NEO-FFI. We gave participants the childhood trauma questionnaire. Another questionnaire was called the Trier Inventory of Chronic Stress, which also includes more recent stress. We measured aggression and, of course, borderline symptom severity. And here are already the findings. These are the figures for the ALHB score, where higher scores reflect slower life history strategies. So in other words, as predicted, the people with borderline personality disorder were much faster compared to the control group in terms of their pace of life. Conversely, they had much higher rates of allostatic load. Again, something that was highly significant. So the accumulation of chronic stress was already measurable in this clinically healthy sample, which were women between 18 and 40 years with no visible signs of somatic disease. In addition, and this is what's already been known for a long time, we found differences in all big five personality factors, especially neuroticism. All differences were highly significant except the one for openness, which was marginally significant, but when controlled for multiple comparisons, it was no longer significantly different between the two groups. And it also in line with predictions, of course, we found higher borderline symptoms or more borderline symptoms in the clinical group compared to the control group. CTQ scores were much higher in the clinical group, as well as the scores for aggression and the experience of chronic stress. This is nothing particularly new, but nevertheless in line with the prediction. If you remember the small table that I showed from Marco Del Giudice, that also high aggression and the experience of chronic stress could be indirect markers suggesting a fast life history strategy. This is a terrible table. I apologize for the small size, but it basically shows that there was a lot of correlation in the expected direction between life history patterns with personality factors, with aggression, with childhood trauma, etc., as well as many correlations among these other measures like personality factors with CTQ, aggression or chronic stress measures. And interestingly, when we explore in an explorative regression analysis, we put several of these factors into the analysis. Neuroticism was actually the best single one predictor of the pace of life measure. In other words, the higher the neuroticism score was, the faster the pace of life was measured with the ALHB. The second best factor and the slope would be almost indistinguishable from this one was childhood trauma. So childhood trauma had more or less the same predictive value for the pace of life measure. And this, in summary, suggests that indeed people with borderline personality disorder seem to be on the fast track, and there could be a need to, as Jeremy has put it, to push the brake button on their individual pace of life. If I have 1 minute left or 2 minutes, I would like to show you 2 slides from a very recent study in another borderline sample, which underscores that we need to take preventive measures also in terms of somatic health of this psychiatric population. We recruited another 50 or so female patients with borderline personality disorder in collaboration with the cardiologists from my university to measure the so-called cardiovascular strain, which is something that can be determined by using echocardiography. And the method that can be applied is called speckle tracking. And the speckle tracking allows a three-dimensional view on the heart, and you can see on this slide that the muscle can be that we can see different sections of the heart muscle where we can look at individual sections or to be specific to the perfusion or blood supply of these specific sections of the heart muscle. And this is what we found, and this is quite fascinating. And I would love to discuss this with you, but specifically with Marinus, because he reported that in his studies, if I correctly understood, that childhood adversity was not a predictor of somatic health in his very large sample. What we found was in clinically healthy people with borderline personality disorder that they had a significantly aberrant cardiovascular strain compared to a control group, and 30% of the clinical group were below 2 standard deviations from the norm, whereas this pertained to only 6% of the control group. And to our surprise, we couldn't believe it, but childhood trauma was highly significant in predicting cardiovascular strain in the entire sample, which suggests that we need to take action very early, from very early onwards, to prevent somatic consequences of psychiatric disorders, psychiatric conditions like borderline personality disorder. All right, these are briefly summarized a few take-home messages that you can read on the web when you would like to have a second look at the slides. So I hope I was able to keep the time, and thank you for your attention. Happy to take a few questions if there is some time left. Thank you so much.
Thank you very much, Martin. That's lovely. Very interesting. There are a couple of questions that are typed at the moment. So can you hear me clearly?
Yes, thank you.
Paul, I was wondering whether Martin, because there is some time left, I was wondering whether Martin can go over those take-home messages.
I'm very happy, yes. Well, do you want to do the take-home messages and then we'll do the questions? That'd be lovely.
Good. Okay. Very briefly summarized. So I think what the previous speakers and I have tried to show is that the early ecological contingencies can have an imprinting-like effect on how individuals experience and interact with social environments as adults, and that based on their early experiences make unconscious predictions about what to expect from the future. And so through the lens of life history theory, I would like to suggest that the behavior of people with BPD is consistent with their expectations, but perhaps only dysfunctional by means of context, because context may suggest that they live in a safe environment where their perception is that they don't. Yeah, and in line with what Jeremy suggested, I think we need to take therapeutic action to find the button how to push the brake on that dynamic, whether it's psychodynamic or other mentalization-based therapy or other approaches is, I think, more or less, I wouldn't say irrelevant, but whatever helps, pushing the brake button is I think, important. And what I try to show is that we may also take action to prevent, for preventive measures in terms of somatic health, because I forgot to mention that we, of course, controlled for smoking. So the numbers and figures I showed were controlled for smoking habits. So smoking is not a major factor, for example, in relation to cardiovascular strain in that group. All right, thank you.
Thank you, Martin. I was just going to say, in clinical practice, I did an audit of the community mental health team. This is not the inpatients. And at one stage, 40% of my outpatients had EUPD. So this is quite an epidemic.
Wow.
And one of the big difficulties I think we all found is actually forming a relationship with them is quite hard. And getting people to turn up again and again, not in crisis. But one of the problems is our colleagues very often get irritated, angry, or reject borderlines, or say they're not mentally ill and discharge them. And so there's a lot of clinical work that needs to be done to help people with EUPD, not having them serially rejected, and in fact the abuse to be continued in a way. So I'll just go on to the questions. First question I've got here is from Simon Taylor, who says, so given mismatch, etc., is this why EUPD manifests in westernization?
That's a very good question. I think this could well be, although I have no data to support this this idea. I know by comparison, I mean, Riyad, you know better than me. By comparison, eating disorders may be a more informative example in terms of the mismatch hypothesis, because as far as I know, eating disorders are more or less absent in developing countries as compared to developed countries, or at least less frequent. And I would guess that the same is true for borderline personality disorder, but don't know precisely.
Well, yeah, I think although there is an overlap, as you mentioned, between eating disorders and borderline personality disorders, there are areas where they can be quite distinct. With regards to EUPD, would you do you think that with greater urbanization and a reduction or an increase in family breakdown and so forth, you know, which is more prevalent in highly urbanized environments and with mobile populations and so forth, do you think that might be a factor in increasing levels of EUPD in westernized countries as opposed to more traditional societies?
Yeah, I would agree with that. It's also consistent, perhaps with Sarah Hirdy's data. My guess is that in smaller societies, the social control is much higher. So the risk of being exposed to emotional neglect or abuse is perhaps lower than in more anonymous societies, especially perhaps urban environments. And I particularly found the hypothesis put forth by Marina's intriguing, saying that orphanages may be a surrogate of infanticide. And I sometimes wonder if people with severe BPD somehow survived physically while being terribly maltreated psychologically, if these individuals would perhaps not have survived in other environments. But this is just a guess. Yeah, I don't have data on that.
No, sure. I mean, I was wondering also, I mean, the term family breakdown is also a euphemism for reduced kinship networks, reduced availability of kinship networks and kinship support.
Yes.
Yeah.
I think there's also something else about the communication in EUPD, in that some of the risk taking in order to gain care might mean less in a developing society than it does in a society with institutional care. It would have a different meaning. So deliberate self-harm, for argument's sake, although that's assuming there is one common meaning to deliberate self-harm, which I very much doubt. Anyway, shall I come on to the second question? This is by Steve Hyham. Is there any significant correlation between BPD and body dysmorphism difficulties?
Could you explain what that? Sorry, I'm not sure if I got this correctly.
Okay. Is there any correlation between BPD, borderline personality disorder, and
yes,
I presume he means dysmorphophobia, body dysmorphism?
Very good question. I think so. Yes. Especially among those who have experienced sexual abuse, many are really dissatisfied with their body shape or outer appearance and so forth. I think there is a connection.
Okay, thank you, Martin. Thank you very much. Riyadh, can I ask you to take this over and close perhaps for us with any advertising for the SIG or?
Yeah, sure. I mean, we have a few more questions and a few more minutes.
Oh, do we? I don't have any questions. Oh, have they come in?
Yeah. There's one by Graham Kidd.
Yes. Okay, no, I'll go through. Sorry, I've just seen that. Sorry, I'd stopped at. Yes, Graham Kidd, this is for Martin. Graham Kidd, insofar as childhood trauma is a factor in BPD, has EMDR been shown to be helpful?
I'm not a specialist on EMDR, but there are a few studies showing that it can help cope with trauma. Yes, so I think the answer is yes, as long as it concerns coping with trauma. Yeah. Maybe not so much other symptoms like impulsivity or self-injury or so. Yeah.
No, I certainly have seen some skeptics. There's an interesting aphorism I heard from the skeptics saying about EMDR: what works isn't new, and what's new doesn't work. So that it is something that has an effect, but it's not very deep, the effect. It's a distraction processing trick rather than dealing with the deeper issues. But we have some benefit in some that don't want to look deeper and can't look deeper.
That's right.
Yeah. Then there's somebody called Alexandra. Sorry. I've got Alexandra Cat. A question to both Martin and Jeremy. If Jeremy wants to put his microphone back on. How do you understand impaired interoception stroke dissociative survival strategies contributing to predictions of what constitutes an embodied or felt sense of self, and therefore safety stroke managing self-care? Any views? Do you want me to read it again?
Yeah, please. Yeah. Please.
A question to both Martin and Jeremy.
Mm-hmm.
How do you understand impaired interoception stroke dissociative survival strategies contributing to predictions of what constitutes an embodied or felt sense of self, and therefore safety stroke managing self-care?
Okay. Impaired interoception is very prevalent among people with borderline personality disorder. We recently did a study about heart rate variability in people with BPD, and found that heart rate variability is also correlated with the experience of adversity as children. So turning away one's attention from internal signals may help in dangerous environments. That's my guess.
Okay. Jeff Lawrence Smith asks, should liaison psychiatrists be considering general hospital environments as institutions which vary from the EEA? I think we've heard a bit of this, haven't we, today? Which vary from the EEA in the same way as orphanages. Are there evolutionary principles that might be particularly useful in general hospital liaison psychiatry?
The question is, I think, quite tricky to answer, at least for me, because when we last met in person, Paul and Riyad, we talked about differences between psychiatric hospitals in the UK and in Germany. So, as far as I remember, you were surprised to learn that we don't have locked wards. So my ward, for example, for people with BPDs is open. So we don't have a high security surrounding there. So we take care for the people in other ways, but we don't lock them up. So
even more surprising was Italy, wasn't it? Which doesn't have a mental health act where you can sanction people.
Exactly. So yes. So another thing is that we can keep people for a longer period of time in the hospital. Like, so we have an inpatient DBT program that runs 6 to 8 weeks, which is, I think, a bit uncommon for UK. Is that right?
I haven't been an inpatient consultant for quite a while. It's very short nowadays. And what I've noticed in our area is many people are under the Mental Health Act, and it's usually people that are severely suicidal or psychotic, and they're in for very short times, seldom 6, let alone 8 weeks.
Yeah.
And the institutionalization, I mean, when I started psychiatry in the 1970s, there were people that had been in hospitals since the teenage years, in fact, all their lives. So people were massively institutionalized and could be in there for decades. So we've sort of gone from too much to arguably too little. Not enough beds, and not enough time.
Right,
so,
right. I see that. Yeah.
Although I would say that, I think being in an acute psychiatric ward at the moment is not therapeutic from a psychotherapeutic point of view.
That's right. Yeah.
Okay, let's move on to Finola Stewart. How do ideas about sexual promiscuity in women, especially young women, who would meet a diagnosis of BPD, intersect with more recent trauma-informed research, which recognizes that many women don't recognize or report non-consensual sex, as such for a variety of reasons, both individual and related to societal views and norms.
That could be a question for Jeremy as well, but I think he's offline now.
Yes.
I think promiscuity is one of many indicators for fast life history strategy, where careful selection of a romantic partner is less important than reproduction. So this is perhaps very sad to say, but the currency of evolution is not well-being, but reproduction, and promiscuity definitely, I believe, comes at the expense of poor well-being, but perhaps well, in terms of reproduction, I'm not so certain.
Well, I certainly remember lots of angry debates about so-called promiscuous women having lots of children in order to gain social housing some years ago. And I thought that was very, very unfair, not only on the woman, but I mean, there may be people that manipulate the system like that, but also it's not the fault of the children.
Yeah, that's true. I mean, I can say, but without exact numbers, that among our patients here, the number of women having many or quite a few children from different fathers is quite high among the borderline population. So it's not uncommon to have a 25-year-old with 4 children from 3 different fathers.
I had
just as an example.
I had a patient, I won't give too many details because of confidentiality, but she'd had 9 husbands, which I thought was the triumph of hope over experience.
Right.
Yeah, and she had children by many of them.
Mm-hmm.
You know, that's quite extraordinary.
Yeah.
But does the extraordinary illuminate the commonplace? Probably not, to be fair.
I think, gentlemen, we need to bring the session to a close.